Ok. Bueno, buenos días a todos. Muchas gracias por estar aquí. Les quiero con mucho orgullo presentar al doctor Kevin Wilkes. Él trabaja en el departamento de cardiología del Cook Children's Medical Center. Es cardiólogo pediatra del Texas Children's, y también hizo un diplomado en imagenología avanzada, y nos va a dar una plática hoy de la detección temprana de cardiopatías congénitas complejas, que creo que puede ser un excelente tema para todos los pediatras. Y bueno, esta sesión por temas obvios va a ser en inglés, y tiene la facilidad de la traducción simultánea. Ustedes pueden activar si no la ven ahorita, la pueden activar en su Zoom. Es un pequeño logo que dice CC, y ahí lo pueden empezar a ver. So Kevin just presented you in Spanish, but thank you very much for being with us.
Of course.
And please welcome, and you can start now. Thank you.
Thank you so much for the invitation. This morning, we're going to talk about early detection of congenital heart disease. And specifically, we'll be focusing on fetal cardiology and fetal echocardiograms. So this morning, we're going to understand the use and the features of fetal echocardiography. We're going to understand and describe how they can influence outcomes in both prenatal and postnatal. We'll talk about some of the delivery room strategies and information that we can understand from fetal echocardiograms, and then also review some prenatal as well as postnatal interventions for our children with complex congenital heart disease. So fetal cardiology is the field within pediatric cardiology that focuses on the diagnosis and management of pregnant moms who are expecting children with congenital heart disease. The forefront of this is fetal echocardiography, which is a focused ultrasound of the heart, more specific than an anatomy scan. It's generally performed around 18 to 20 weeks. There are certainly earlier or first trimester fetal ultrasounds and fetal cardiology being performed. But the most information that we're going to get on anatomy is generally around 18 to 20 weeks. And we can see in this heart, this is an example of a normal fetal echocardiogram with the right ventricle more anterior, the apex of the heart pointing leftward, and the great arteries crossing. At the end of the clip, here you see the aorta, and then the pulmonary artery going into the branched PAs. That is in contrast to this example where the great arteries do not cross. You see, here's the right ventricle, and the aorta comes off in parallel to the pulmonary valve coming off from the left ventricle. And this would be an example of detransposition of the great arteries, or DTGA. So there are various indications for a fetal echocardiogram or evaluation by a fetal cardiologist, many of which are maternally driven. So pre-gestational diabetes can cause certain congenital heart disease, one of which we just looked at, transposition, as well as gestational diabetes can cause hypertrophy of the ventricles. Other maternal indications, such as autoimmune disease or lupus, can cause complete heart block. Fetal PKU, maternal rubella, or family history of congenital heart disease can increase your risk. In general, the risk of congenital heart disease is anywhere between 8 and 10 per 1,000 live deliveries, but that can increase as much as 10% in patients with a family history of, say, left-sided heart lesions. Certain medications that moms are on can increase their risk of congenital heart disease. And certainly, if the high-risk OB identifies any fetal abnormalities, that would be an indication as well. We get both diagnostic and prognostic information, which can change the frequency of needed repeat evaluations. Certainly, less complex heart disease may only require one evaluation, where the diagnosis can then be explained to the family. But more complex disease, which we'll be looking at, requires frequent evaluations throughout pregnancy. We often start medications for fetal arrhythmias, such as SVT or VT. In some instances, and we'll talk about this later, fetal interventions while the baby is still in the womb can be helpful in changing the outcome. We learn how the baby's delivery course might be, and so we can understand what resources we will need at certain hospitals, maybe changing the delivery plan from a more local or community hospital to a tertiary or referral center. In some instances, vaginal delivery isn't safe for babies with complex congenital heart disease, some of which we'll discuss this morning. It can also provide us information on timing of the first intervention and how soon the baby might need to go to the operating room. This can also be important as we're providing counseling for morbidity and mortality for the parents, and so they can understand what their child's life might be like. And that includes a counseling session after the fetal echo is performed. So during the same visit, we're able to look at all of the images, take in all of the data, create that plan that we just discussed, and then talk to the mom about what this all is going to look like. Now, certainly it can be overwhelming. And that's why I also think that repeat evaluations by a fetal cardiologist can be helpful, because it's a lot to take in. We've trained for a long time to understand complex congenital heart disease, and we're asking these parents to kind of understand it as well. But I think their education is incredibly important to understand not only what their child's life will be like, but what the rest of their pregnancy will be like and what to expect as their child grows. Now, certainly this is no perfect test, and we have limitations to what we can see. Generally, small, insignificant features like bicuspid, aortic, or pulmonary valves are difficult to assess on fetal echo. Certainly an ASD or a persistent PDA is hard to assess because as fetal circulation, those are normal structures. And so we can't predict if they'll go away or not. Coarctation of the aorta is probably one of the true congenital heart disease that is most difficult to see on fetal echo, as again, the patent ductus arteriosus or PDA is still open and hasn't closed yet to result in a coarc. So we'll discuss two main cases and how diagnosis and also prognosis during fetal echo evaluations can be helpful. So our first case, a mother presents for an abnormal ultrasound. The fetal echo demonstrates tetralogy of Fallot. And so you can see here, again, as we sweep and focus on the heart, the apex is pointing leftward. The right ventricle here is anterior and thickened. The pulmonary valve here comes off normally and crosses the aorta, but the aorta overlies this large ventricular septal defect. So that forms the four portions of tetralogy of Fallot. The good news is that this pulmonary valve, while thickened, looks like it measures normal size with good branch pulmonary arteries. So that helps us determine the important prognostic information, such as, is this a pink tetralogy of Fallot or a blue tetralogy of Fallot? And that helps guide our delivery room and newborn care depending on the degree of pulmonary obstruction. So as we just discussed, tetralogy of Fallot has four main components. Here's a picture example of what we just looked at on the fetal echo with the overriding aorta and hypoplastic and narrowed pulmonary artery. on our fetal echo, the main thing, as we mentioned, is that we're focusing on the ductus. So this is a structure that is open in almost all fetuses, and the direction is really important. In normal fetal anatomy, the PDA allows for blood to pop off from the lung arteries and go out and contribute to cardiac output. So the direction should be right to left. In some patients with tetralogy of Fallot who have severe narrowing or severe right ventricular outflow tract obstruction, the fetal PDA actually goes in the opposite direction. So it goes from left to right to allow for additional pulmonary blood flow. And that can be seen here. If we look, here's the pulmonary artery, and here is the aorta. And you can see that both are red. And so in any sort of echocardiography, as you know, red is coming towards the probe, so going in this direction. And they're both going in the same direction, meaning there's enough pulmonary blood flow coming off. As opposed to this fetal echocardiogram, you can see that the aorta has red flow, but the pulmonary valve actually has blue flow. It's going away from the probe, meaning that there's additional blood flow coming from the PDA into the much smaller pulmonary arteries to allow for additional pulmonary blood flow. And that tells us that this baby, once they're born, will require additional pulmonary blood flow and earlier surgery. And these arrows again indicate that blood flow direction that we talked about. So in pink tetralogy of Fallot, we have a near normal pulmonary blood flow size, minimal outflow tract obstruction at birth. And when the PDA closes, that we generally follow these patients in outpatient, as you know. We elect to repair these kids around 3 to 6 months of age, as long as they haven't developed TET spells or hypercyanotic spells, because many of the published results have shown that earlier intervention can lead to more ventricular tachycardia later on in life. In our patients with blue tetralogy of Fallot, those are the ones that have opposite direction of blood flow from the PDA. They have a smaller pulmonary valve size, increased outflow tract obstruction, and they need a stable source of pulmonary blood flow for when the ductus eventually closes. So we generally will approach a staged palliation, either a modified Blalock-Thomas-Taussig shunt, which is a surgical shunt placed from the innominate artery to the right pulmonary artery. We generally don't have to do this operation anymore, as we're now able to place a stent in the ductus arteriosus before it closes. And so you can see here's the ductus, and this is the stent that's placed. So if we look at an angiogram, so this catheter here is in the aorta coming up, and you can see that it contrast highlights the aortic arch here, the patent ductus arteriosus here, and the pulmonary valve and pulmonary artery here. We focus on the pulmonary valve, you can see the leaflets, while the annulus size appears normal, are thickened and dysplastic. So that's why annulus size in fetal echocardiogram can only give you so much information. The degree of obstruction and muscle in the right ventricular outflow tract is far more important. And so this baby needed a stable source of pulmonary blood flow. So again, the main pulmonary artery is here, the aorta is here, and the PDA is here connecting the two vessels. And so our interventional cardiologist is able to place a catheter and a wire across the PDA, and a stent here is loaded onto a balloon and can be expanded. And again, this is minimally invasive through the femoral artery and not requiring open heart surgery. Here, the stent is being expanded, and you can see now it's wide open and allows for easy flow of blood from the aorta into the pulmonary arteries. And this will last, again, until we generally elect to do a complete repair, which is around 3 to 6 months of age. Other medical management can be helpful, such as beta blockers, which decrease the spasm of the muscle here in the right ventricular outflow tract. We're mainly looking for those signs of hypercyanotic spells or TET spells, which would be blueness or decreased perfusion um, to the lungs, and which is demonstrated here by the muscle hypertrophy in the right ventricular outflow tract and increasing right to left shunting, causing more desaturated blood out to the body. And then, as you know, treatment includes calming, oxygen, and increasing afterload by placing knees to the chest to increase the amount of left to right shunting across to the aorta. And this is that repair that we talked about, which is closure of the VSD. And in some cases, in those that the pulmonary valve is too small, a patch has to be placed across the pulmonary valve annulus to enlarge it. In some cases, if we can spare the pulmonary valve, meaning we don't have to place this patch, that will mean that a child will only require that one surgery for the remainder of their life. If we do have to place a patch and the valve becomes leaky or incompetent, then valve replacements would be needed as the child grows. Our second case will also focus on a complex congenital heart disease, but we'll focus now also on fetal intervention. So another mother presents for an abnormal ultrasound. This time, the intracardiac connections are normal. You see a right ventricle here, you see a left ventricle here, but you'll notice that the function of the right ventricle is normal, whereas there's not much function of the left ventricle. It's severely depressed, though it's normal in size. A patient like this who presents around 19 weeks will develop hypoplastic left heart syndrome if left untreated. And so this here, as we'll show by color, demonstrates critical aortic stenosis. There's severe fetal obstruction of the aortic valve, and that is causing the severely depressed left ventricle. The delivery room care and newborn care depends on many factors. And again, we have opportunities for fetal intervention that we need to monitor. So with color, you can now see that there is severe mitral regurgitation coming from the severely depressed left ventricle. And you can also see a very narrow jet of aortic stenosis. When we place a Doppler over that mitral regurgitation, this evaluates the speed at which the blood flow of that mitral regurgitation is going. And we're seeing that it's going at about 4 meters per second, which to us tells us that the left ventricle, even though it appears severely depressed, is able to generate a pressure of 61 millimeters of mercury, which means that the contractility or the squeeze might be depressed, but that the function is still working. It's just hindered by the severe aortic stenosis. And again, we'll focus on the very narrowed aortic valve and flow acceleration here. And what we see, if we look at the arch, we see the ductal arch here coming from the PDA flowing normally. And we see this blue flow going in the opposite direction, which we discussed in the last case. Opposite direction is bad in fetal cardiology. That now we know that there's inadequate blood flow across the aortic valve such that there needs to be retrograde filling of the ascending aorta from the descending and ductal arch. So this tells us that even though the size of the left ventricle measures normal to mildly dilated now, if left untreated throughout the rest of this pregnancy, this baby would develop hypoplastic left heart syndrome. And so at some centers, fetal intervention is entertained. And so this is a picture from Boston Children's Hospital, who pioneered this, and we work closely with them on any of our fetal patients that need to go for fetal intervention. And so while the baby here is still in the womb, an ultrasound guided needle is placed across the mom's abdomen and uterus and through the baby's chest wall. And a catheter is now placed through the heart muscle of the left ventricle, and a balloon is placed right across the aortic valve and allowed to expand, just like in the cath lab if we were to do an aortic valvuloplasty, to allow for more blood flow across the aortic valve and essentially cure the aortic stenosis. So these images are a little bit harder to see, but you can see a needle here is coming through the fetal chest wall and into the apex of the fetal heart. A wire from that needle is then placed across the aortic valve, and you can start to see what this balloon is being deployed. So now you can see the wire and the needle across the aortic valve here. These two white lines demonstrate the wall of the ascending aorta. And now the balloon is expanded across the aorta. And now with color, you can see that there is no longer aortic stenosis. Because the valve has to be torn open, there will be some degree of leakage or aortic regurgitation from the valve, which you can see here as this narrow jet. But most importantly, the mitral regurgitation has improved, the aortic stenosis has resolved, and you can already see that the left ventricular function has begun to improve. So on follow-up fetal echo, the left ventricular function has normalized. There is some flow acceleration, but no significant aortic stenosis. The mitral regurgitation has resolved. Here we can see the aortic valve opening nicely and a good size annulus of the aortic valve, and again, good right and left ventricular systolic function. And importantly, now we see normal red or antegrade flow across the aortic arch. Now it's not needing to fill backwards into the ascending aorta. And so we have many different indications for patients that we know that fetal balloon aortic valvuloplasty may work well. Generally, this can be formed around 19 to roughly 34 weeks, but it's a very time-sensitive diagnosis. You saw that already in our first example there, that the left ventricular function was already declining. Over time, if left untreated, this is unreversible and would develop into hypoplastic left heart syndrome, where the left ventricular muscle becomes more fibrotic and more scar tissue forms than muscle. So as soon as we identify a baby with aortic stenosis and significant mitral regurgitation, we must act quickly. And we have a lot of different measurements and different understandings about which babies do well. And so the green represents babies that are successful. The ascending aorta size is normal. That is a positive feature. If the LV pressure is greater than 47, that is also positive. And we said in our patient, it was in the 60s, meaning that the squeeze and the function of the left ventricle is still normal. Once we see that the function is lower and it can't generate a higher pressure than 47, then these are not as successful. And we know that this has maybe developed into unrecoverable or irreversible HLHS. Another indication or something that we look for in our patients with HLHS is a restrictive atrial septum. So as we mentioned, the patent foramen ovale is open in fetuses, and this is extremely important in HLHS, where there's no way for blood to exit the lungs and go out to the rest of the body through either an atretic or hypoplastic mitral valve. While maybe only 10% of cardiac output is going to the lungs in the developing fetus, that still represents incremental blood flow that needs to return. So in this patient, you can see this continuous blue flow at the atrial septum that we normally don't see in fetuses or in fetuses with HLHS. and there's some continuation and a gradient of pressure across the atrial septum. When we look at the pulmonary veins, we see that the blood flow coming back from the lungs into the left atrium is going forward and reverse, so red and blue, meaning that blood comes back from the lungs, but then gets kicked back into the lungs because of the restrictive atrial septum and no option for anywhere else for it to go. And these patients over time would develop something called nutmeg lung, or pulmonary lymphangiectasia. So another fetal intervention, ultrasound-guided needle is placed across, again, the maternal abdomen, the uterus, and into the chest wall of the fetus to now place a stent across the atrial septum to allow for free return of blood from the lungs out to the rest of the body. Now, in our first fetal intervention, there was no stent placed. You're able to open the valve and it will stay open. In these patients, however, we have found that just a balloon over the rest of the pregnancy and further gestational weeks, that hole would get smaller or more restrictive again. So a stent is needed to keep it open. So now here you can see this patient truly has hypoplastic left heart syndrome. You see a large right ventricle here. You see a much smaller left ventricle here. This is the right atrium and tricuspid valve, and here is the left atrium. So a needle is placed across the right atrium, across the interatrial septum, and into the left atrium. You see a flash of brightness here, which represents a laser perforating across the atrial septum. A wire is then placed from the right atrium into the left atrium here. And then a stent, just like in our patient with tetralogy of Fallot, is expanded. So here you can see a single white narrow line, and then you see two parallel white lines, and that represents the stent. And with color, you can now see that there's unrestricted blood flow across the atrial septum. And why do centers do this? Well, again, we discussed that restrictive lung flow in patients with HLHS can lead to what's called pulmonary lymphangiectasia or nutmeg lung, where the lungs themselves don't develop normally. The architecture, as you can see here, is very rough. This is an example of a fetal MRI. And we know that in 30 days, the mortality of patients with hypoplastic left heart syndrome and nutmeg lung is around 57%. And so really, Boston Children's and Texas Children's have really pioneered this work. And we, again, work closely with our teams down at Texas Children's and in Boston for those patients that we identify. I think it's important that as rare as these fetal interventions are, they're not performed by many centers. We want to work closely and identify these patients locally and abroad so that we can get them in when necessary. I think we work as an excellent pipeline to identify these patients and screen for those that may benefit from this fetal intervention. And then finally, we'll discuss an interesting case that I saw that we'll talk about again, what no fetal intervention or postnatal cath-based intervention, but something we just don't see every day. So a mother presents again for an abnormal fetal ultrasound. And what we can see here is the chest wall. And you can see the lining of the ribs here and the anterior chest wall. And a major portion of now both the left ventricle and the right ventricle are extruding or sticking out of the chest wall. Here's the majority of the heart mass here, and here is a contractile portion of the apex of the left ventricle and an apex of the right ventricle. And this represents something called ectopia cordis, or heart outside of the chest. In addition, we see a portion again of the right ventricle, of the left ventricle, The anatomy can be better seen here, that there are two great arteries, an aorta here, and a pulmonary valve, which is smaller here, coming off of the right ventricle. There's a large VSD here. Here again is the elongated portion of the left ventricle that's sticking out of the chest wall. And you have two normal AV valves. Here's a mitral valve and a tricuspid valve. And so here's a diagram of what the anatomy of that heart looks like. It's, again, as we discussed, ectopia cordis, where this line represents the chest wall, and a portion of the heart is sticking outside of the chest wall. There is double outlet right ventricle, where both outlets, the aorta and the pulmonary artery, are coming out from the right ventricle, and the aorta is in front. And there's also two SVCs. The issues that we see in patients with ectopia cordis is that through the pregnancy, the chest wall has accommodated the amount of heart that is in the chest and isn't growing to accommodate the amount of heart that is outside of the chest. So this is not an anatomy that the heart can just easily be placed back in once the baby is born. So often a protective plate is needed for the baby to allow the baby to continue to grow in the NICU and not suffer any injury to the heart muscle that is sticking outside of the heart. And then as the baby grows, the chest can be reconstructed to fit the heart back into the chest. In addition, we have this heart anatomy that also needs to be repaired from within the heart. And this often needs to be with a closure of the large ventricular septal defect and also switching these great arteries back, because as you see, the aorta right now comes off further away from the left ventricle than it should. And so this portion of the aorta can come over here from this valve and now be the aorta. And then the pulmonary arteries can come from over here from the right ventricle. So in summary, field echocardiography yields very important diagnostic information. I think, not only can we screen for babies who are at high risk for developing congenital heart disease, but our high-risk OBs do an excellent job of identifying those babies. And by making the diagnosis, we can discuss with families prognostic information as they make plans for the delivery of their baby. We can discuss treatment information and make appropriate plans and identify all necessary team members to be ready for when the baby is born. I like to think that we have 20 weeks of planning before delivery. So if we identify a pregnant mother with a fetus with complex congenital heart disease, at 20 weeks, we have, the rest of her pregnancy, so around 20 weeks, to figure out the plan that we need to start any medications, to plan for any interventions, to get ready for surgery, to plan for the right delivery hospital, to get the baby to where they need to go, as opposed to before fetal cardiology was around and we were making these decisions after the baby was already born, and there was a lot of excitement. Interventional cardiology continues to improve outcomes, specifically postnatal, as we mentioned in the PDA stent case, where now we can avoid that initial surgery with a BT shunt. But we're also seeing the development of fetal interventions that can change the outcomes prenatally. Time is an important factor. Again, I think we have 20 weeks of planning, but we need to make these decisions quickly and thoroughly. And so our team at Cook Children's works with both our neonatologist and our high-risk OBs in a weekly meeting where we discuss these impending pregnancies so that, again, the whole team is aware, in addition to our cardiac ICU and our surgical program. So I want to stop there and see what questions people have had. I see that there may be some in the chat, and I want to thank you again for the opportunity to come and speak to you.
Thank you very much, Doctor. Yeah, I saw someone that raised her hand, but I think maybe it was an accident, but no sé si alguien tiene alguna pregunta que quiera hacer al doctor. I do have a question about the surgery,
Mhm.
about the fetal surgery.
Mhm.
Uh, Overall, what would be the maternal um, fatalities because of the fetal surgery
Yeah.
or in today?
Yeah. So currently, I would say maternal mortality would be 0%. They have not yet lost any moms with the fetal intervention. Uh,
Okay.
Fetal mortality is much different. Certainly, this is a very invasive procedure for the fetus. And the aortic valvuloplasty, which is the first one that we talked about with the balloon across the aortic valve, that is quite low, close to 10 to 20%. In the fetal atrial septal, where a stent is placed, that is much higher, closer to 50 percent. And I think the increase in mortality in that procedure is because a stent is used and placed. And that stent, being metal, can erode if it's not placed exactly where it needs to be. Whereas opposed to the first intervention, a um, since a stent is not placed, generally the babies recover quite well. Now, with our medications, we talked about in certain cases for fetal arrhythmias, we might need to try different medications. There are a lot of maternal side effects of these medications and risk of arrhythmia as we load the mom with a certain amount of medicine so that that can then cross the placenta and treat the baby.
Okay. Yeah, my concern was the of course the maternal mortality, because even if it's very, very, very low, it's unacceptable. Yeah,
Yes.
that's what I would think, no? But
Yes.
and the fetal mortality is quite high.
Mhm.
Would you say it's higher if you let the baby get born and have surgery later
Yeah,
on
that's a
with
good
these
question.
kind of procedures?
Yeah. So with the atrial septal stent placement, again, that we know that if the baby gets born, that our mortality after birth within the first 30 days is around 50 to 57%. But if we do the intervention, we know that our mortality is maybe 30 to 50%. So it's slightly better, not great in those patients. In those with aortic valvuloplasty, the first intervention that we talked about, I really think that the graph that showed the success by color, let me pull that up again. That I think really helps drive should we perform the procedure. And so again, these successful ones were in green. I think it's worthwhile approach if we think it's going to be successful. I would say that our surgical outcomes in HLHS generally greater than 90% survival. And I would say nationally, that survival is closer to 80%. So in many cases, it may be helpful to perform this intervention, especially if you feel that it would, if the baby would respond if you caught them early enough. However, if you're worried about the size of the mitral valve or the size of the ascending aorta and it's more of a yellow or red, then we would say that our outcomes for the treatment of HLHS would probably be better, knowing that, however, there are complications as patients with single ventricle physiology grow.
Okay. So if I get it right, most of the diagnostics should be done and in fetal echocardiography, of course. And if, for example, here in Mexico, here in the Angeles Lomas Hospital, we have an excellent service of perinatal medicine. if we get to diagnose one of a cardiopathy, a complex cardiopathy like the ones you described,
Mhm.
and we should analyze the possibility of a fetal surgery. Could that be done with you?
Yes. So I
With
think,
I mean with you and your team?
yeah, so I think the easiest way is when a patient is identified, reaching out to us, and certainly here I've included my email here at the bottom. We are always happy to review any fetal echocardiography or anatomy scans from the high-risk OB team to see would they be a likely candidate. We're also happy to review any difficult anatomy where like we mentioned in the patient with tetralogy of Fallot, would they need to change their delivery plan to be near a center that can offer that intervention? And so again, I think we are a great pipeline to, you know, evaluate and treat patients with various forms of complex congenital heart disease.
Right. Yeah, that's great. We have a question of Rodrigo Hernandez Benitez. He's a pediatric cardiologist here in Mexico City, and he's asking, in patients that required aortic dilation in uterus, in what time after birth they required surgical intervention like the Ross intervention?
Yes, that's a great question. So in the patient of the example that we discussed, where you actually saw a very good outcome, uh, this patient didn't require any neonatal intervention. They needed a cath when they were 6 months old to further balloon dilate the aortic valve because there wasn't significant leakage. And so it's unknown yet if this patient would even require a Ross operation, which I think is quite remarkable, given that when they first were presented to us, there was a risk of HLHS. In the described research of the aortic dilation, that you can see, again, these are the success rates and the patients that made it. So again, it really depends on the measurement of the ascending aorta, the LV pressure. There are still patients that undergo this intervention with poor mitral valve inflow time, small ascending aorta, small mitral valve size that don't make it to a biventricular repair. And then in addition to that, there are some that may at some point require a Ross procedure, but I think it's certainly not that all patients will need it. And I'm impressed that our patient here that was identified early and treated again before 27 weeks has yet to require a Ross.
Right. I think it was quite clear that usually they wouldn't require the Ross procedure, right?
Yes. Or
Mhm.
the single ventricle palliation.
Okay. Okay. Anyone has any other questions? ¿Alguien más tiene otra pregunta? Well, I think that's it.
I, I have
Then
a last question, if I can,
please,
if I
Monica.
may.
Yes, of course.
For tetralogy of Fallot, which I am guessing it's like we see that pretty often, no, as far as congenital heart disease. I know there's a lot of discrepancy about when is the best time for surgery, no, whether it's more about the weight of the baby, more about the age of the baby, or maybe the dexterity of the heart surgeon. So what would you say about when is the best time for surgery in those babies?
So I think first and foremost, it's the dexterity of the heart surgeon. So we have three phenomenal surgeons here that in some cases, if the baby is large enough, we have explored newborn complete repair. The most important portion of patients with tetralogy of Fallot is the muscle that is going towards the pulmonary artery, or what's known as the infundibulum. This muscle in our research has shown that that is the leading cause of ventricular tachycardia or ventricular dysrhythmias. And so if the surgeon feels that that can be spared and that muscle doesn't have to be cut or injured, then less scar tissue forms and less ventricular arrhythmias form. In those patients that it can't be, then we would elect to perform a later 3 to 6 months repair. I think there's discussion around the country of many smaller transannular patches, but again, that leads to how successful and how dexterous your surgeon is, that they can avoid that muscle. Again, not causing early problems, because obviously babies tolerate pulmonary insufficiency very well, but having late-term problems such as ventricular arrhythmias.
Okay, thank you.
Okay, great. Thank you. Any other question, Monica? Is that okay?
No, yeah, sure. Thank you, thank you.
Okay. Okay, there's no more questions. I think we can finish. I don't know if you would like to give us a final message, Doctor.
Yeah, I'll leave my email up here again. I think it's a great opportunity that you guys have invited me to come and speak. And I love the exchange of knowledge and the discussing of patients that now, this technology has given us, that, we can easily review patients together, whereas years and years ago, it was much more difficult. So I think these shared resources and shared knowledge can be helpful. And even if your patients don't have to come up to see us at Cook Children's, we're always here as hopefully a helpful consult. And then certainly if it's something that you feel we could help benefit your patients, we're always happy to be there for them.
Great. So it's great to hear that. And of course, we would like to maybe next year invite you to come here and see our hospital in person. So or to give us a lecture again, but in person. And here in Angeles Lomas Hospital, we are very delighted to have you here, and thank you very much for agreeing to be here. And thank you, Monica, for the link.
No, thank you, and thank you, Dr. Wilkes.
Thank you again.
Thank you very much, Dr. Wilkes.
Thank you.
Thank you very much. Bye.
Bye.